Hello, everyone. My name is Jordan Heimerman, and for my policy and politics presentation, I will be talking about KanCare. To start, we'll talk about a little bit of the history of how KanCare came to be. So, this is a program that has actually evolved from Medicaid, but it is special to the residents of Kansas. It was originally introduced by Governor Sam Brownback and Lieutenant Governor Jeff Collier back in 2011. The overall goal was to improve outcomes and establish financial sustainability for Kansas. So this is actually a joint bill. It was introduced to the Kansas Department of Health and Environment along with the U.S. Senate because the Secretary of Health and Human Service is a part of the U.S. Senate. And this was because it was a modification to a federally funded program. So that was why they had to introduce it to the U.S. Senate along with the Kansas Department of Health and Environment. So in order to start these types of programs, you can't just introduce the bill. There's a lot of research and other things that go into approving the bill. So just a little timeline of how KanCare came to be. Back in 2010, Kansas Medicaid began studying health outcomes. So they were asking hospitals, the public, everyone around the state to tune in and to ask questions about how can we improve health outcomes for the state of Kansas. In January of 2011, the governor meetings with stakeholders began, so interest groups and people who were interested in donating and applying grants were discussed with. In April of 2011, the mission statement to serve Kansans in need with a transformed, fiscally sustainable Medicaid program that provides high-quality holistic care and promotes personal responsibility. And that was the main mission statement that they wanted for KanCare. In June 2011, and then throughout the entire summer, Kansas held public forums for the public and for stakeholders to ask really any questions that they had about this new program. And they also gave the public the opportunity to give suggestions for how to improve it. January 26, 2012, Kansas submits Section 1115 demonstration concept paper to CMS. June 27th, 2012, Kansas signs contracts with Amerigroup Kansas, Sunflower State Health Plan, and United Healthcare Community Plan of Kansas. So these three insurance groups are the ones that are the privatized groups that help KanCare run. In December of 2012, the program was officially approved by CMS, and January 1st, 2013, KanCare officially went live. On the legalistic side of things, KanCare did have to go through different committees to get approved. The state of Kansas, Kansas Department of Health and Environment, received the proposal and they came up with expenditures for the services. So, for example, physician consults, personal care services, and rehabilitation services were all possible expenditures, and they formed a paper to submit as well. It was then proposed with a Section 1115 demonstration to the U.S. Senate or Secretary of Health and Human Services because, as said earlier, Medicaid is a federally funded program. It was then approved for a 5-year period, so through 2013 through 2017. Section 1115 is a part of the Social Security Act that allows states flexibility to improve their Medicaid programs, which is what Kansas submitted. And it is important to note that stakeholders also gave input in those public forums before committee presentation. So they gave ideas for access to care, benefit options, and many other ideas in those public forums. Stakeholders, or those involved, are some of the most important people and groups involved in plans like these. So consumers make up about 28%, advocates 21%, providers make up 30%, health plans are about 1%, community partners are 10%, and then there's just other anonymous groups, about 10%. There are grants from multiple health foundations given, including Deloitte Consulting, Healthcare Foundation of Greater Kansas City, Kansas Health Foundation, and Reach Healthcare Foundation, along with many others. They all participated in public forums held in Kansas to give ideas about this new program, like said earlier, so these stakeholders actually felt like their voice was heard by having these public forums. All parties of interest should be considered stakeholders. Others would maybe include the insurance companies involved, such as Amerigroup Kansas, Sunflower State Health Plan, and United Healthcare Community Plan of Kansas. And then the impact and reason for interest would be you would save money for both the residents of Kansas and for the state as well. Vulnerable populations are protected, promises to improve quality of care and services, elimination of silos between populations and providers, and it makes people responsible for their own health outcomes. So who actually benefits from KanCare? That would be those eligible to use it. So primarily those that are eligible to use Medicaid are those that are going to be able to use KanCare. Obviously, there are going to be some variations, but it is based on income level. So children are able to use this, families, like I said, based on income level, pregnant women, those who are aged a little bit older, and those who are disabled. So to be more specific, those over the age of 64, those who are a caregiver or parent to a child under the age of 19, and then those that fall below the income line are those that qualify. So obviously not all programs are perfect. KanCare, along with the person who started it, Governor Sam Brownback, have gotten a lot of scrutiny. So what are some of the adverse effects of KanCare? If you are moving from one state to another, specifically from another state to Kansas, so let's say you lived in Colorado and decided to move to Kansas, you would have to specifically apply for KanCare because it is localized to the state. If your income is above that limit, then the user has to share part of the cost. It is not available for immigrants or refugees, which are oftentimes some of the most vulnerable populations we have. Privatized programs, which some argue can limit use and can dissuade some people from using it. KanCare has been accused of having a lack of transparency with not only the users, but stakeholder groups as well. And due to the lack of transparency and some other issues, the program was actually not approved for renewal in 2017 unless they did make some changes. KanCare has actually gone through quite a bit to have, in quotes, a final version. To the right, I've included the actual letter of the original approval for KanCare. So at first, it was officially approved by the Centers for Medicare and Medicaid Services on December 27th, 2012, and then put into effect on January 1st, 2013. The approval was good for 5 years, which ended on December 31st, 2017. Like I said before, due to complaints from stakeholders, providers, and Kansas residents for lack of transparency and promises not being kept, it was actually rejected for renewal. KanCare then re-renewed and was approved February 19th, 2020, and it is currently available for use in Kansas. The way they were able to do this was that improvements were made to the Delivery System Reform Incentive Payment Program, or DSRIP. This helped the hospital's incentives to improve quality of care for re-renewal. Cost with programs like these not only affect the people using it, but it also affects the state because the state is the one running it and the one paying for a lot of the services. So for users, based on the income level, if criteria are met, they do not share any of the costs. However, if you do go over the criteria amount, then you do have to share some of that cost. To the right, I did include a chart that kind of shows what the income level is for a certain number of the members of your family. Applying for KanCare can cost anywhere from $20 to $50. Typically, there really are no co-pays involved when you do have KanCare. They do have a program called Spend Down. This is a medically needy program, and it offers coverage for those that do go over that max amount. You pay somewhat like an insurance deductible, and the period is over 6 months. So an example of calculating spend down would be, let's say somebody makes $795 in Social Security income. You would subtract $495 of the protected income level, and this would give you a $300 monthly spend down. If you multiply 300 by 6 months, this would equal $1,800 total spend down for a period. So that's kind of how they do that for those that go over that line. For the state of Kansas itself, the estimated cost for the state for 2022 would be $8,274,741. So as you can see, these programs are not always cheap. So, for me personally, I love the state of Kansas. I plan on living here for most of my life. And so, this policy will most likely affect people that I know and love. I do want the state of Kansas to do well. And with Kansas being so low on the healthcare totem pole, ranking 41st out of all of the states in the United States, I think it does have room to improve. Because I do work in healthcare, I will probably come across people who use this program quite a bit, and I will need to help them to understand their situation. I will maybe answer some questions about their hospital stay or maybe what medications are covered, things like that. This is also important for team collaboration. So, let's say a nurse working with a case manager for insurance and billing purposes. How can my patient get the best care for the best price? What medications are best for them? What discounts can I find? All of those sorts of things. Like I mentioned earlier, no program like this is perfect, and KanCare definitely isn't one of them. Some of the changes that could be made are that the application process needs to be smoother. There have been cases where people have been rejected from nursing homes due to backlogging. So their application just takes way too long, and the nursing home cannot accept them because they don't have any insurance. A lot of providers, actually, especially dentists, have dropped out of accepting KanCare patients because Brownback did cut their reimbursements by 4% to help state budget. This needs to either be raised back up or another solution needs to be found if they want more providers available, especially in Kansas when you have more rural areas. Out in western Kansas, there just aren't as many providers available for use. And then another change could be change of privatization. With 3 different insurance companies, it does not make reimbursement or payments any easier. This may need reform as Kansas residents are not getting better health outcomes at lower costs as promised. Thank you for watching my presentation on KanCare, and I hope all of you have a great rest of your semester.